Good afternoon, everyone. My name is Stephanie Romano, and I'm one of the regional paramedic educators with Base Hospital. My apologies, you've been sitting around watching a screen. We forgot to turn the microphones on. So again, welcome to our webinar. This one happens to be on the LHSC experience in Israel in terms of the CBRNe team and how they can bring those experiences here locally. If you're new to the webinar experience, you'll see a PowerPoint presentation, and you'll hear voiceover as well, this live voiceover by Dr. Mike Peddle and Paul Robinson. You'll also have the opportunity to ask questions via the chat box in the bottom right-hand corner of your toolbar. You'll also have the opportunity to raise your hand and ask questions live if you have a microphone. So we'll leave the live questions for the end. Otherwise, we'll take questions via your chat box throughout the presentation. And so without further ado, here are your presenters.
All right, well, let's try this again. Sorry about that, but we'll get started and we'll talk a bit about the LHSC CBRN team. Our objectives today, what we're going to go over, we're going to talk a bit about how Israel responds to MCI and hazmat incidents. And then we'll talk a bit about how we can bring their experience to LHSC and its implications for the EMS system around Middlesex. We'll talk a bit about the new developments at LHSC, which is the CBRN Emergency Response Team, which is what the EMS system will essentially interact with for the most part at LHSC should we ever have an event, and we'll talk a bit about how you're going to interact with them towards the end of the talk. So Orange Flame 6 was an exercise in Israel that we were invited to go over and attend, and this was a list of the team that went. Most people will probably recognize most of the names across the list there, along with all the other white lettering that goes after those names. But it was a good group of people that went over and spent a week in Israel. What we wanted to get out of that was to really just get a good sense of how does Israel, which unfortunately for them have had multiple of these events, respond to MCI and hazmat events, and then try and bring some of their experience and training back to LHSC. The list on the screen there is sort of the official list of all the things that we wanted to do and see when we came back, but overall it was really just to get a good sense of how they do it and why they do it that way. So we'll talk a bit about where we went. MDA is essentially the equivalent of MLEMS, I guess, around Southwest Ontario. They are the sort of the head EMS system, or the overriding EMS system, but in Israel it's actually a countrywide program. It's not localized. We met with their director of operations. We met with people from the Ministry of Health, as well as the police force and the Homefront Command. We went around to different stations throughout Israel, looked at their dispatch centers as well as their equipment. We were fortunate enough to get to go to the paramedic school, meet their chief instructor, and even to get on base in Israel and see the IDF medical simulator that they use for training their military medics. Got to go to a few of their hospitals, and finally, towards the end of it, we actually got to observe a sort of regional drill that included a fair number of hospitals, EMS systems, and other groups. So a quick background on Israel. So Israel itself has a population of 7.7 million people. The vast majority of those people live within the urban centers across the country. They have 27 general hospitals, of which 26 of them have functioning emergency departments, and they have 6 level 1 trauma centers spaced out over the country. All total in the country itself, they have 14,500 hospital beds. So why did we go to Israel? Why did we look at going there? Why were we fortunate enough to get to go there? And I guess the biggest thing is that they have a lot of experience. Unfortunately for them, this is they've had more than 2,000 events over a 7-year period. Of those events, there was 9,344 casualties, broken up into mostly minor, as they usually are in large-scale events, but a fair number of moderate, critical, and even fatalities associated with it. When you look at those terrorist attacks, 155 of them were true suicide attacks, so suicide bombers, and it makes up more than 50% of the fatalities of the actual total number of casualties within their events. So they have a lot of experience, unfortunately, or fortunately, depending on how you want to look at from learning perspective. One event is the Maxim Restaurant, which occurred in October 2003, and it's interesting to just look at the timelines for these and how efficient they are at doing their job. So this event had 37 casualties associated with it. 11 were dead on scene, 6 critical, 14 moderate, and 17 mildly injured individuals. The call came into their dispatch center at 08:51. By 08:55, they had their first responders on scene. By 08:58, they had 1 ALS crew and 7 BLS crews on scene. By 09:01, they had their MCRV, which is a multi-casualty response vehicle, on scene with 13 BLS crews and 2 ALS crews. First evacuation, 14 minutes from the call and 10 minutes from first on scene, they had their first criticals leaving the scene. And by 09:17, they had transported all 26 patients. So from the time the first crews arrived on scene with vehicles, so 08:58, the first ALS and BLS crews were on scene. So within whatever that is, so just under 20 minutes, they were managed to triage, transport, and treat 26 individuals. So compared to most other systems, I think that this is an amazingly efficient system for dealing with mass casualty events. So a little bit about their medical system. It is quite similar to the Canadian healthcare system. All the citizens are entitled to medical care according to their National Health Insurance Act, very similar to ours. They have central control over their healthcare system, which is slightly different than us, but generally the same. And they are overall responsible for all of the medical services, including hospitals, EMS. Interestingly enough, their national medical system actually coordinates all the emergency preparedness through the Homefront Command. And that is probably one of the big differences that we see between their system and our system when it comes to responding to large-scale events. Like I was saying, it's this national system that actually develops all of the doctrines and protocols for emergency preparedness and mass casualty and hazmat responses. They actually have daily networking and interfacing with all of the agencies that are based on that or interact on this. So this includes Homefront Command, the Israeli police forces, military, hospital systems, EMS systems. Have a daily networking and interfacing. They have a joint communication system, including a national database that actually tracks all available hospital beds and hospital capacity issues across the entire country. And that is a live system all day, every day kind of thing. The other things that they do that are quite impressive and actually is probably one of the biggest bonuses to their level of preparedness is that they actually have annual assessments of preparedness. So all hospitals, all of the different services that are involved actually have to do some, or are assessed annually by the sort of the national branches to look at how well they are doing and whether or not they were prepared should they have a significant incident. And on top of that, they have national or regional training and drills that occurs annually for all of the involved agencies. So from a training perspective, from an assessment perspective, they always are at a state of readiness, and they always have a sort of a good handle on whether or not they're prepared and what the deficiencies are within their system at any given time. So probably the biggest agency involved in sort of the initial response is MDA, and that's essentially the Israeli National EMS System. It coordinates all pre-hospital care, but it also coordinates the National Blood Services, similar to the Red Cross here, or the Canadian Blood Services now. They do all emergency medicine instruction for paramedics as well as sort of emergency responders and just general first aid. And they are the civil auxiliary to the IDF for medical response. So when you look at how, just from a pre-hospital system, how is MDA involved? Well, on the left side there you can see from an EMS perspective, they train and organize all the first responders as well as all the paramedics, both BLS and ALS, which are equivalent to our PCP and ACP paramedics locally. They actually, all of dispatch is run through MDA, and we'll talk a bit about their dispatch system and how it works and its efficiencies compared to some of the other options. But they have a dual national and regional system with 24/7 medical control. So in their national control center, there is a physician that is online in the dispatch center at all times to give medical control and oversee complex medical cases. And their dispatch system is actually paramedic-based, so all of their dispatchers are practicing paramedics. You have to be functioning as a paramedic to work as a dispatcher in their system. Finally, the third part of their sort of pre-hospital system role is education. So they run the training facility for PCP and ACP paramedics. They also do community first aid instruction for all of their first responders and community responders, which we'll talk a bit about. There are a couple of other additional sort of training modalities within Israel, so you can go through the military program, which is MDA approved, I guess is the best way to look at it. And there is also a university program there that is also MDA approved or certified. MDA itself has 1,700 employees broken down over EMTs, paramedics, supervisors, people that are paramedics that work primarily as dispatchers, and then also in the areas of logistics training and then in the blood services. The big difference with MDA is the volunteerism, and we'll talk a bit about sort of volunteerism in Israel in general, but they have over 11,000 volunteers nationwide that participate and actually function essentially as employees to some extent. They work in the blood services, first aid instruction, and then a large component also in the first responder program, which is something that is we'll talk a bit about and really does significantly boost their ability to respond to day-to-day calls as well as mass casualty events. There's one national medical dispatch center and then 11 regional dispatch centers similar to what you would see around here from a dispatch setup. So when you look at a response, so the Israeli response and how do they respond to a mass casualty event, you can break it down into the first step, which is the initiation of the response, which is primarily done through dispatch, and then a surge response for people and equipment to respond to any given event. Once you've initiated the response, then there's the scene response that includes MDA and their first responders, paramedics, as well as how they use bystanders, and then the role of the Israeli National Police within any given response. And finally, there's the final part, which is the transportation to hospital and then the hospital response for that. Now, we'll pretty much focus on steps 1 and 2 today. We're going to leave the hospital response because it's not really quite so, from a surge response within the hospital, what we're going to look at in this talk. So when you look at the initiation of the response, it's the first thing that happens in Israel is they actually divide up dispatch as soon as an MCI is confirmed. So once they confirm that it truly is an MCI event, dispatch is divided in that the regional dispatch center will then just take routine calls, and any calls that are as a result of the MCI actually gets sent up to the National Dispatch Center, and the National Dispatch Center will have a specific area that is just slated with dealing with the MCI, so doing all the dispatch stuff for that MCI. On top of that, they actually use a completely separate dispatch program once they've determined that it is an MCI. And the dispatch program is impressive in that it automatically sets up perimeters for any given event. It sets up ingress and egress routes, routing for all emergency vehicles going in and out of the scene. And the importance of this, especially when you look at some of the different responses that had to occur in Israel, is that it allows the police to know what routes are coming in, what routes are going out, so they can protect those routes from secondary events around whatever MCI it is. They also have live vehicle location and status tracking, so they can see exactly where vehicles are, what those vehicles have in them, who's in them, patient transport information, and where they're going, and that is all live on the scene. So, and that allows for tracking, and they also have live satellite imagery of events, so they can actually look down and actually see what's going on the scene, and they can give their operators information as to, you know, turn left at the big red building that you see, kind of thing. So if you look at it, no, I know this is not Israel, but similarly, they have a similar base program where you would actually see that their dispatchers would see this map. They would plot the routes as well as where their hot, warm, and cold zones are. They know which vehicles are in which zones and which groups are with, or which operators or medics are in the different zones and what their roles are at that time. On the screen here now, you can actually see their National Dispatch Center. You can see the large screens that they use for actively tracking calls, as well as where their equipment is. This is called the National Overflow Area. So if you call their equivalent of 911 in Israel and the regional dispatch center is too busy handling calls, after I think it's either 4 or 6 rings, it automatically goes to the National Overflow Area. So a dispatcher in the national dispatch center will then take the call and do all the work similarly to the regional dispatch center. So once you've decided that it is an MCI response and they've switched it over to the National Dispatch Center and they've set up their system, the first part of the response is getting people on scene. And how do you get enough people on scene in a short time to deal with these MCIs? So one of the first things that we were impressed with is the volunteerism and first responders that Israel has. And we'll talk a bit about how it works. But they have a large number of people that carry pagers, cell phones 24/7 completely as a volunteer. And on any given event, be it an MCI versus just an emergent medical call, their dispatch centers know where each of these first responders are based on the phone locators. And they will get a text sent directly to the computer automatically sends a text directly to the nearest first responder. And it says, you know, you have a event at this address, and usually it's within 200 to 400 meters of where that phone is. And then they can either say, yes, they can respond, no, they can't respond. And if they say, yes, they can respond, then they can track that phone right to the event. And all of their first responders essentially have first responder bags, which allow for basic first response type treatment. Beyond that, all of their off-duty medics, or many of their off-duty medics, will actually take work vehicles home and use them as their primary methods of transportation when they're off-duty. And if there is an event, are available for immediate response. And then finally, at any training courses that are going on in the region, if there is a vehicle assigned to that training course, then 2 medics that are at that training course are actually assigned to that vehicle. Should there be an MCI response, they would leave the training session with that vehicle and go to the event. So they actually have pretty good surge response, and as you saw in that one event or example that we gave you, you know, within a short period of time, they had 7 vehicles with people on scene. So the next question is, how do they have enough equipment to do that? So they have a large base of equipment and ambulances. They have ambulances in storage that are maintained all year round for use in the event of a large-scale event incident. And all of their equipment is donated. So they have these huge drives trying to get donations from across the world. And when you look at ambulances in Israel, you'll actually see all of the ambulances have names like Canadian MDA, UK MDA, India MDA, and so all of these places will say, that's where they're from or where the money was raised to have that equipment. They also have what are called MCRVs, or multi-casualty response vehicles, and there's 24 of them spaced out over the nation, and they're basically equipped to help responders. So, not all responders are going to have their equipment bags with them when they arrive on scene, and so these MCRVs actually have BLS and ALS kit bags, backboard stretchers. They have a work desk, a generator, and everything, so you can actually see one of them here. So basically, when one of these shows up, all you need is a person who knows how to operate the equipment to show up then and actually work it. So if you look on the left there, you can see a vast number of backboard stretchers and kit bags. The picture on the right there is looking in through the side. You can see there's actually a workstation in there for an incident commander, as well as a generator. They also have supervisor vehicles across the nation as well, and these are equipped with cameras that can be controlled by dispatch. So if you look here, this is the supervisor vehicle. The picture on the right, you can see that this camera has actually been elevated with lights on. It has and it can be controlled by dispatch. So dispatch has full control over this camera. They can turn it 360 degrees around. It has a very long range lens on it, so they can actually get a very good picture live of what the scene is and what's going on. You can see in the back also it is fully equipped with stretcher equipment to respond to an event. You can see here there's a local control box, as well as, like I said, it can be remotely controlled by the dispatch center, so they can get a sense of what's going on at scene at any given time. On top of that, they have a whole bunch of other cool things that help them respond to different events. They have armored vehicles that are bulletproof. They have operations vehicles, like you saw in the background of the last picture, which are just basically equipment vehicles. They have logistics vehicles, which we'll show you, as well as mobile ICUs and negative pressure transportation stretchers. So as you go through here, the top left corner, you can see one of their mobile ICUs, which basically in the back of that looks like you're in an ICU bed. The bottom right corner there is one of their armored ambulances. This is an operations vehicle, so this vehicle can actually be brought anywhere and can do decon of the ambulances in the case of a CBRN or sort of biological or chemical-based substance within the ambulance. And you can see that that one was donated by Sweden. This is the self-contained isolation stretcher. So this was a pretty cool toy, I guess. Not really a toy, but they have 24 of them based across the country. And it's basically it's a negative pressure isolation chamber that you can put people in and do all of their care without having to worry about exposure for yourself. So you can see here we decided to take some air and stuff them in there and then poke at them with the big rubber gloves, which, as you can see from the picture on the right, he didn't really appreciate, but we all thought was pretty funny at the time. So when you look at the system itself, I mean, it has a number of strengths. When you look at the national level, just the formulation of the professional training programs that they use, there is a national sort of culture of being prepared and learning about being prepared. And then on top of that, the compulsory training, the compulsory drills, as well as the compulsory assessments of preparedness that happen every year. Within the hospital system, all of the staff are trained for NCI events. And there's a significant assimilation of knowledge amongst the staff in that all of the staff train together, despite, it doesn't matter where you work within the hospital system, they train together to work together in the case of one of these events. There's an 8-hour compulsory training and drills that all staff have to do, and they all are expected to participate in post-event debriefing. And then when you look at just the EMS system itself, besides just its sheer equipment and personnel availability. They do combined training with other emergency services, so the Israeli National Police Service as well as the fire services. Once again, there's annual nationwide exercises as well as regional exercises that they participate in, and then just these exercise cycles actually go through various simulation of realistic scenarios, and they cycle through them. So one year it may be chemical, the next year it may be radiologic, it may be explosive, and it is sort of prepared in secrecy, and no one knows anything about it until the day of the event. So some of the specifics, I guess the biggest thing from a national perspective is just the integration of the services. There's a national command center, there's the centralized dispatch center, the fact that all of these services train together, and there's an integrated doctrine and protocol. So essentially the national system sets up these training protocols and doctrine that allow the systems to work, and then that gets filtered down to the individual sort of systems-based level, and they train on it regularly. There's a significantly advanced sort of communication system between all the different agencies that allow them, the heads of these places, to know each other well and work well together. So in the event that something does happen, they actually know each other and are not trying to figure out what people's roles are during an event. The teleconferences. The other thing that we found interesting was that police are always scene command. So it doesn't matter what the type of incident it is. When police arrive, they are the scene commander or the incident commander. And their police force is trained to be incident commander. So there is no sort of debate over who's in charge. They are in charge of the overall scene, and they direct all the other services. And that seems to work well for them, and it avoids a lot of conflict on scene, I have to say. We won't talk a lot about the hospital system, but like I said, they certainly have some significant strengths within their training and education, in that all hospitals are required to have plans, all staff have to be trained in the plans, all hospitals have to do mandatory drills. Security is a little different down there. In the event of an MCI, one of the things you want to secure is your hospital, which already is done down there. All hospital perimeters are already guarded 24/7 by either IDF or the security force. Every ambulance is searched on arrival. It doesn't matter if it's a CTAS 1 versus a CTAS 5, MCI versus no MCI. Every ambulance gets searched before it gets to the on-hospital grounds. Decontamination, they've got a fair bit of experience with this as well, and they actually have fixed outdoor decon structures at all their hospitals, and all of their staff are trained in how to use those decon structures. It's a whole lot easier when you're somewhere warm 24/7 to do outside decon. And depending on the type of event, they actually have IDF forces that are trained specific to a hospital. So in the event that there is a CBRN event that is a part of a military event, they have reserve forces who their only job is to respond to the hospital and do the CBRN decon. Finally, surge capacity is built in. All hospitals in Israel have to have a plan for a 10% surge. So 10% of their hospital beds for a surge response, and that has to be built into their plan, and they have daily reporting to this national sort of central bank that allows for bed tracking and monitoring of availability and capacity within their system. So as you see in the picture here, this is a first responder moped. So some of the first responders, like we talked about, these volunteers who have first responder training and kits, actually get to have these mopeds that they get to drive around. And mopeds are the mean of transportation in Israel. They're crazy drivers down there. You think they're crazy here, you should see them down there. So just from a resource-based thing, like we said, an unbelievable trained responder pool. So all of the volunteers, like we said, these first responders that are trained as volunteers and carry cell phones that are GPS enabled with responder kits, and like we said, even the scooters, are used to augment the paramedic services in the event of an MCI and in the event of war, because a large number of the paramedics within their program are reserve medical forces, so therefore they will get called up to be used for in the event of war. And their equipment, like we talked about, they have an amazing fleet of vehicles that are available and at any given notice, and a large national stockpile of equipment. One of the other big things that they have is all of their vehicles are equipped with level C PPE as well as body armor and helmets in the case of an actual event.
Mike, we actually had a question come through, if you don't mind taking it. It's a great question. The question is, does fire actually play a role in the Israeli medical care on a daily basis?
So I don't have a definitive answer, but my understanding is fire may provide some first responder type coverage similar to here, but from a true medical response, no, fire tends to do fire's job. Correct. So one of the other big strengths of the Israeli system is the whole idea of dispatch, with the National Medical Dispatch Center acting, one, as a backup for regional dispatch if a region is overwhelmed, the 24/7 medical control. They have direct access to the National Command and Control Center, which would be the sort of the overriding control center for any real large-scale MCI that was sort of nationwide, and has access to all of the, hospital capacity and control issues. As well as the Regional Dispatch Center, they do some very interesting things there. One, besides knowing ALS and BLS crew availability, they actually can do secondary casualty relocation, and one of the things that they do is they actually send a dispatcher to the locally affected hospitals. So any hospitals that are involved in any response will actually get a dispatch representative to the emergency department, and their job is purely there to coordinate patient transport, and they will have direct access to emerge capabilities at that time, patient volume, equipment arrival, that kind of thing. So they actually have someone from dispatch in the emergency department trying to help with sort of patient allocation, relocation, and movements. So I mean, that in and of itself just significantly increases the ability for good communication within the different responding organizations. The other thing is their computer system and being able to track all of their responders, so they know not only what responders are near an event and can respond, but also what responders are in the event and where they are in the event. Like I said, we talked about earlier, this whole separate system for MCI response separate from their day-to-day routine program, which allows for planning of entry and exit routes to the scene, allows for those entry and exit routes to be secured by police from a safety perspective, and tracks the sort of safety perimeters. And like I said, it also tracks the national resource status, so what is the capacity of the hospitals within the region of an MCI, so they know where they can send people. And that is sort of a real-time tracking. So other things that they have is a well-trained population. So all of their population is required to do military service, and therefore have had some training in response to a event. So all of their population have some not necessarily MCI training, but at least first aid training. And the volunteerism in their country is amazing. Like we said, 11,000 volunteers just within the NBA, and that doesn't include within their fire services and police services, which have similar sort of volunteer numbers. Given the fact that they have a well-trained population, they actually integrate bystanders into their protocols for MCIs. So they use bystanders to do first aid, apply pressure, move victims. That is actually part of their MCI protocol, is the use of bystanders during an event. And finally, just pure experience. Like we said, they do way more training. They train on this on an annual basis, right from the level of EMS all the way up to nationwide control centers. And unfortunately, they have a large amount of actual real-life experience with these events as well. So this is kind of a good time if there are any questions, because now we're going to move into a bit about what we're going to sort of, some of the differences between the Israeli system, what we currently have, and how we see some things changing in the future.
Well, ironically, Mike, that was a question that just popped up. The question was, are we looking at implementing any of these changes, and if so, what? But it sounds like you're going to address that.
Well, that's pretty much where we're heading, so that was a good segue. I appreciate that for whoever sent that one in. So differences for CBRN events between Israel and London. So one of the differences between Israel and London is that all of their vehicles are equipped with level C PPE and body armor. So this allows all of their medics to actually do care in the hot zone and treat patients that are currently contaminated, if you want to consider that. That is unlikely to ever make its way to North America, let alone to Southwest Ontario, for a number of reasons. First off, it's going to be an infrequent event to actually have one of these actually happen here compared to the sort of the day-to-day state or potential in Israel. And the cost becomes very prohibitive to try and put all of that equipment in vehicles and then have upkeep, maintenance, and training on that kind of stuff. So thus it is unlikely that we're going to implement that type of training and equipment within the local area. So we will remain sort of a cold zone after patients have initially been decontaminated, at least in London area, by London Fire Department. In Israel, they triage people a little differently. Basically, you are immediate or everything else, where here we still use either a SALT or an RPM style triage into different categories. And we'll talk, we've certainly looked at, are there benefits to one way or the other. I think the biggest impediment to implementing a sort of a everything else plus red triage is just the amount of equipment we have to transport people. We don't have the same capacity to move 26 people in 18 minutes. I think will probably be our biggest impediment to doing that. I don't know if Paul's got any ideas.
And my impression too was that for religious reasons, they will never call somebody a black. That everyone gets treated there. So that also is a triage system that's in conflict with our process.
Exactly.
Can I just quickly add in there? There's a question about what the acronym SALT stands for and what that means.
Oh, okay. So SALT is a new MCI triage tool by the CDC, which is slowly making its way into use across North America. And we'll probably see it hopefully here, at least in the hospital system soon, and maybe even in the other systems soon. It stands for Sort, Assess, Life-Threatening Treatments. It's very similar to RPM. It has a few minor tweaks, but it sort of takes, the development of it took the best pieces of numerous different MCI triage tools and kind of melded it into one. In Israel, they differentiate between a hazmat call versus a toxicological MCI that's sort of as a result of a CBRN active war kind of thing. The likelihood that chemical warfare would happen in Southwest Ontario, I think, is hopefully pretty small compared to the hazmat event, and we'll likely not differentiate the two should it ever happen. Israel, given the fact that their paramedics can wear level C PPE and suits and treat and transport in that setting, allow their vehicles to get contaminated and then leave them essentially contaminated through the event, where here, given the fact that hopefully the patient is going to be decontaminated at scene, they'll likely again then at hospital, The vehicles are decontaminated between casualties. And this comes down to, similarly, in Israel, there's no actual decon done on scene. They take the clothes off, they put them back in the back of their equipment, and they transport and treat. Where here, decontamination is done on scene before they even make it to EMS, and then it will be repeated at hospital under the assumption that there may be some residual contamination. And then just their perimeter safety setup. So a little bit about the team, what's going to happen in the end when all of these people get transported. So LHSC has kind of renewed its CBRN program in the hopes of trying to get it back up and running to a sort of a reasonable capacity. And so we've developed a new team, or 5 teams essentially, which are going to be brought online over the next year to 2 years. The 2 teams are going to be site-specific for Vic, 2 teams are site-specific for university, and then there'll be a final mobile team that can move between any site wherever it was needed. Team members are made up of RNs primarily, as well as some EDTs, SSWs, ESWs, NukeMed, and RadTech people. Their training is about 8 hours of total training. 4 hours of it is done through online modules, and then a 4-hour practical exercise with PPE. First team is actually almost completed at Vic site. They'll have their practical training later this month, and then they'll be up and running, and hopefully within another 6 to 8 weeks we'll have a team set up at UH as well. Basically what happens is, hopefully, once an incident is identified, if it is a large-scale incident, EMS, by either EMS or fire, dispatch would notify triage, which then would notify the charge nurse, who then should notify whoever is on call or the lead person for the CBRN team at that time. And then that person makes a determination as to what kind of response we need. If there are more than 5 patients that are going to be transported to hospital, then that would activate a full team response. So ideally they would set up the full decon setup at one or both sites, depending on where people are going to be transported. If it's going to be more of a one-off or two-off, in that there's less than 5 patients involved, then what will happen is that you would transport them to hospital, and any team members that are on shift or activated to help, but they will be deconned by EMS, either outside or within the sort of decon hallway at that site. So the biggest things to remember is really just early notification. Currently, with the current system, given the tent requiring somewhere between 8 and 10 people to set up, and the number of people needed to get that equipment out, set up, and running, it takes quite a time frame from the time you notify us to the time that we can have a functioning decon team for a large-scale incident. You have to remember that you will be stopped in the setting of a large sort of MCI event, because the hospital will be on lockdown. You won't be able to just sort of walk them into the back of the Emerge, and that most of the handoff will be done sort of outside in the ambulance parking area. And in the event of sort of small-scale kind of stuff, most of the decon will actually be done, hopefully, prior to you guys even having to pick them up and transport them, but then will be finished by yourself and anybody that is on site from the CBRN response team to help you. And with that, I'll open the floor for more questions.
Okay, so there's a couple questions sitting on the floor. You, I think, clearly addressed what the hospital is doing in terms of training. The question is, what kind of training would be practical locally for both medics and supervisors so that they're true on-site commanders, given that college training is somewhat inefficient or insufficient?
So just to clarify the question, so the question is what would be good training for EMS personnel to be the incident commander?
Yes,
is
that's
that
what I
essentially
the
question? You know, that is a tough question. It certainly requires additional training. There's no question that to be an effective incident commander, you need additional training in how does MCI work and how to interact with other agencies, what is sort of the incident management system. The question is as to where to get that training or how to get that training doesn't easily exist, I don't think, within our current system. There is some emergency management training through EMO as well as for true ICS type of training, which is incident command training, but it would not actually be specific to EMS's role within a mass casualty event. It would be more specific, more sort of general to how does an incident commander function within the within a large scale event.
There's another one here. Question is, will the CBRN team be able to respond to other areas other than LHSC, such as Grey or Bruce County, or I guess any other distant site?
So the LHSC's team is essentially designed for LHSC. All hospitals in Ontario are supposed to have the capability to respond to a hazmat CBRN event locally. My understanding is most hospitals received the equipment back in about 2004 and the initial training around that same time to be the local response. LHSC's mandate is to be the regional area for that, or the regional support for that, but every individual hospital should actually have its own response plan.
Good. I don't have any other typed questions. We'll leave it open. Oh, actually, I do. Question is, has the inclusion of 23 field ambulance military reservist medics been linked up for optimal response?
Yes and no. We have certainly had some discussions, pretty much high-level discussions at this point as to how we could integrate 23 field ambulance into a response plan in the event of a large-scale MCI, but at this point it's really been sort of high-level discussions as opposed to practical application of the field ambulance at this point.
Okay. If there's any other questions out there, feel free to type them in through the question box, or if you have a microphone and you'd like to ask a question live, feel free to raise your hand and I can unmute you, and that way you can talk. Doesn't seem like we have any other questions, and so we'll wrap it up. Huge thanks to Paul and Mike for a great presentation, and keep an eye on your email for our next webinars. Thanks a lot, guys. Take care. Have a great day.